So this week, week 6, we're going to be doing 2 chapters, one on hematological and immunological dysfunction, and the child with cancer. We're going to hit you with some of the stuff that goes on there. Remember, week 8's coming. I need to know what diagnosis you want. Brittany, I'll get back with you. I do see you have a question there. Don't worry about it. Um, I think it's a great subject for you. Okay, whichever whatever way you want to do it, it's fine with me. Um, please give me your diagnoses because I'm trying not to have all of the same thing, and I know that if I don't request it, I will have like 10 of one. And I want to learn something too, so teach me something because I do learn something every time I go and grade your reports. All right, anybody with any questions? Okay. Remember, you can send those things in early. I'll grade them. I'll send them back to you so you can get your best grade you possibly can. So you got to do it soon because the last week is hard on me because everybody is sending it in. All right, chapter 43. Hematological, immunological. When we think of that, we think of how do we measure it? And the easiest way measurable is your complete blood count, right? We can see your white counts, your neutrophils. We can see your hemoglobin, hematocrit, red cells. We can tell a lot just by that simple CBC. Now, in cahoots with that, together, a history and physical examination, for instance. You have a child that all of a sudden has no energy, just looks pale, just not his normal self. Well, that probably is an iron deficient anemia, which means there's not enough iron. So it could be a low hemoglobin hematocrit. So symptoms assessments will guide you to what you're going to be looking at your blood. We know that food, dairy are poor iron sources. So those green leafy vegetables, and of course that liver that everybody loves, mostly not. I absolutely do love it. My husband, ooh, don't even try to serve it to him. But it is a great source of iron. And any child who is getting frequent infections, sick all the time, let's look at that CBC. Do they have a good enough immune system in their white cells, right? And of course, bleeding, that's looking at platelets. And that can look at, are we bleeding so much? Our hemoglobin hematocrit are getting too low. So anemia is the most common of all hematological disorders of children. We know that when you don't have red blood cells, what happens to the child? Well, what does a red blood cell do? It carries iron and it carries oxygen. So if you don't have red blood cells carrying iron and oxygen, well, the cells aren't being fed and they're tired and they get tired easily. So let's think about what we need to do, right? We need to get more red blood cells there, more iron, and more oxygen to the cells, and I'm going to feel much better, right? Now, there's all different types of anemia. I mean, we think of iron deficient anemia, that's the one. Well, it depends on the blood cell. What happened? Was it they died too quick or they don't make them? What's going on? So we're going to go into some of those different things. And of course, they say in children that hemoglobin is less than 10 could be anemia. But remember, infants will have low blood counts because they're not making their own yet. So let's look at the age too. Now, anemia does a couple things to the body. So all those cells pack it into the vessels and they just woof right through the vessels all over the body. Well, when there's not a lot of cells in there, they sort of bounce off everything. And one of the ways you could tell a child anemic, not only by the symptoms of being tired, paleness, all of those things, but listen to the heart. You're going to hear that swishing in the murmurs. It's like so evident. It swishes through and it is a different sound. It's not like a of a VSD or an ASD. It's more like a as it goes through the valve. So now body don't like it. So the heart will tire out if we don't do something because not enough cells. It's making the heart work harder and there's less oxygen and less iron. So again, cognition, cyanosis, growth retardation. Now, this is out of your book. This is all of your anemias. So we can see some the cells aren't produced, some they're lost quick, and increased blood cell loss for some reason, probably bleeding, I would think. And then increased red blood cell destruction means they're in there and they don't last long and they burst. So decreased red blood cell production. Most of the symptoms are about the same. Okay. It's that fatigue that you'll see. You'll see tachycardia, the heart's trying to work hard, and maybe even tachypnea because you're just trying to breathe the oxygen in, but there's no cells. So the heart works faster, then you breathe faster, and there's still no oxygen, there's still no iron as much as you want. But all of those symptoms are the same. And, we know that will all lead to cardiac failure if we don't fix it. So, nutritional. Iron deficient anemia, most common. It's just not getting enough iron in the body. Now, which child would be more susceptible to iron deficient anemia? It's your toddlers. And why? Those are those picky eaters. And we've gone from mom giving breast milk and vitamin D supplements, which helps with the iron, and or iron fortified formula, cereals, etc. And it's gone. Now they're drinking whole milk. There's no iron in it. And they're not getting iron because they don't like this, they don't like that, and they're picky, and it's macaroni and cheese and a chicken nugget, and that's all they want, right? So, iron deficient anemia on toddlers is extremely common. So, something to look for. There's also B12, that's the intrinsic factor. It's not there, so it can't digest carbs. Now, bone marrow failure. Aplastic anemia, and we're going to go into what all of these means as we go further, but the body's not producing the cells the way it should. And then we're going to get into leukemia later on and talk about the white blood cells, et cetera, and viruses. We know acute blood loss, and it could be from nosebleeds. A child who doesn't have good bleeding coagulopathy, platelets, proper PT, APTT, blood levels, the child's going to bleed. And sometimes just picking the nose a little bit after upper respiratory, dry mucous membranes, they bleed and they bleed and they bleed. And it can get them quite severe. And sometimes epistaxis is going to tell us other stuff that's going on. And I'm going to go into that too. And of course, hemophilia. Those are the ones that don't have all the things in the blood they need to clot their blood as quickly as it should. Then we go over into increased red blood cell destruction. On top of the list, sickle cell anemia. We've all heard of sickle cell anemia. It's sickle shapes, and they just die quickly. We're going to go into that too. Thalassemia, extremely similar to sickle cell. I call them the rectangular shaped cells, and they burst. And we're going to go into what that is all about. And this G6PD, believe it or not, I had never heard of it, and a mother taught me it. It is something to do with glucose and the body and red blood cell hemolysis. So they even have, and I found it because I had to medicate a child with some ibuprofen, and they couldn't have the sugar in the ibuprofen. So I had to call the pharmacy and get it, and then I looked it up. The sugar tends to cause red blood cell hemolysis. It's a question I don't know if I've ever seen. I'm just telling it to you because it's there and you're probably wondering. Okay, the other one is either things like drugs or toxic radiation and all of those things. So you got a child in, they're anemic. Well, what type of anemia is it, right? History, physical, CBC. Then look, what is their number? Now, sickle cell children, by the time they come in a sickle cell crisis, they're always, their hemoglobin hematocrit can be 6 and 18, 5, 15. If you're 7 and 21, that's a pretty good one for a sickle cell child. But that child is really struggling. That heart's working hard. We have to help it, help the body. We will transfuse. And even coming into an emergency room, they start transfusions in emergency room. That's how serious the matter is, okay? So do we need to get an IV in? Do we need to give nutrition? Do we just need to give volume? Now, do we need to give oxygen? Will it help? Well, that's one of the most controversial things. With anemia, if you don't have cells, that don't carry oxygen. Does extra oxygen help? So that is the scenario, but they say to put it on. Better to try than not try. And of course, save energy, bed rest, don't let that child go crazy. If the mother is sitting on a chair and that baby wants to sit in that, or that 4-year-old wants to sit in mother on the chair, you work with the child on the mother sitting in the chair, because guess what? They're going to burn less energy and they're going to feel better, right? That's what we do and why we learn all that other stuff too. So assessment, let's look at the kid. And then of course, racial ethnic background, sickle cell disease, Mediterranean is thalassemia. So a lot of, your background can guide us where that anemia is. And of course, always a history, but let's rule out the obvious that there's no GI bleed, right? Don't assume it's anemia because it's a type. It could be a GI bleed, and that's the tricky part. And again, pair your child. You're going to start an IV. We're going to make it numb. It's not going to hurt. All those things that I tell you to do. And because that decreases the amount of oxygen they need and it keeps them calmer. And it's what we want. So, iron deficient anemia. You know, my Christian at that age put a pile of broccoli in front of him like that, and he would dig into it, one of his favorite foods. Now, he was weird. He's not a normal child. Most children don't like broccoli like that. So, iron deficient anemia is when you don't get enough dietary iron. And we know, as I said, when you're young, infants, you're getting it through mom or cereals or formulas, etc. The other group of children we need to watch for is adolescents. Remember, they're in that body image and they really don't eat because they're too fat and they want to be skinnier and they want to whatever, or they don't have time, or they're saving their lunch money for other things, all of those things. These children are not eating properly. So they're at high risk for iron deficient anemia also, and you can see why. Milk babies is when they were feeding just whole milk to the children, the infants, instead of formula or breast milk. That's what the milk babies means there. So, how do we take care of iron deficient anemia? Well, we give them iron rich foods, or we're going to put them on some sort of iron supplementation. Remember, children will get liquid iron. It is dark brown and will stain teeth. What do we know about iron from pharmacology? We do it on an empty stomach with orange juice. Because why? The stomach breaks down the iron, makes it usable. It's the acid. And if you drink orange juice, the orange juice will break it down more. Never with milk. Oh my gosh, never with milk. That coats the stomach and the iron just might as well go away, right? So through a straw, save the teeth. With orange juice, that's the best case scenario for that right now. Now, sickle cell, African American and Native Africans, all the groups that we would look at. If both have a trait, parents have a trait, each child has a 25% chance of having the disease. So you have to have both parents with a trait in order to get sickle cell. Now, let me explain sickle cell my way. So sickle cell disease is these funny shaped little hooked little cells. And blood flows from the heart all the way down and through the bifurcations all the way down to wherever. The knees, the elbows, the chest, it's everywhere. There's blood. In the head, it's too. So bifurcation, and this little sickle goes, oh, I can't get through and get stuck. What happens? Blood can't go down. It's covered. So all the cells stack up on top and it causes that swelling and causes the pain. And distally, you're going to have pain and even death of tissue. So why do we have sickle cell? It's because the vessels are too tiny. So what is our priority? First thing we need to do. Now, they hurt. These kids are in severe pain, but you're going to treat the symptom, not the cause. The cause is tiny, itsy bitsy little veins. Let's get fluid and make them bigger and beefy. Put warm on it. dilate that area, and that will get the blood flowing and it will start coming back to where they want to be. And of course, in your other hand is the pain medicine. Absolutely. And they will get morphine or Dilaudid or whatever really strong stuff. They don't use Demerol in children anymore, if you've ever heard. It causes a lot of seizures, one of the things. Although the textbooks haven't caught up with that yet, to tell you the truth. So, what is sickle cell? It's an obstruction that causes backup, which causes hypoxemia of the area because nothing's getting there, no oxygen, and cell death and pain because now all the nerves are inflamed. It doesn't feel good. So, why do you get sickle cells? Well, it's an autoimmune disease. In any autoimmune disease, stress always. That's a big one. But if you can imagine, sickle cell are all basically related on how blood flows. So keeping hydrated. So these children can play sports. There's nothing to say no, but they better have a water bottle or something next to them and drink, 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 drink. Or with the sweating, what's going to happen, right? So anything that alters the body's needs for oxygen or transport, going up in an airplane, doesn't that also press cabin pressure? So flying, what should they do? Hydrate more, better before they get on. Any trauma, ecchymosis, infection, of course, fever, and as I said, that stress, dehydration is the big one. And today we are screening all of our children, okay? Part of it so that we know. So what's the first thing we do? First of all, they're stressed, most likely. Let's sit down, get an IV in, and the priority is IV fluids. Sickle cell. Let's treat the reason for the sickle cell, crisis. All right? Put heat on it. Of course, look at the electrolytes. If they need blood, give them blood. Most of them do have a fever. And remember, any child who's autoimmune, sickle cell, rheumatoid, CF, any of them, anyone with a temperature of 100.5 is told to call the doctor immediately to get on antibiotics. That was a HESI question, where if you are immunosuppressed, you have no immune system that can fight. So at 100.5, they will give you antibiotics. Whether it was a virus or not, they're not taking chances with immunosuppressed children, okay? Now, sickle cell children, when they're born, remember, their immune systems aren't great yet, right? So from 2 months to 5 years, they give them one penicillin dose a day. It's like a prophylactic. It's like a child born without a spleen. They don't have a big immune system. They give one dose of antibiotics a day. And and what they do is they're going to monitor the reticulocyte count. How are they producing cells? What's going on there? And of course, with these children with low H&H, we're gonna replace that blood because again, we're worried about heart failure. Priority, get fluids in, give them something for pain with, when heat to dilate it, and then get that blood up, and that's your other fluids you'll infuse. Now, there's no cure. They say maybe a bone marrow, but that's still in contemplation. They don't know. Again, it's always supportive and prevention. Prevention, keeping hydrated. Have a fever, get to the doctor right away before you burn off extra fluids and now you're dehydrated. That's the whole concept there, okay? We know that bacterial infections are the leading cause of death, but taken care of, monitored closely, sickle cell can live for a really pretty good life. So, just what I just said there. Thalassemia. Well, you learned a sickle cell, right? Let's learn about the rectangular. You see, I love them. It's just rectangle looking shells there. These are in descendants of people living near the Mediterranean Sea. They found that this is it. And they have these little rectangular red blood cells, and they don't last long and they burst. What's inside a red blood cell? Oxygen and iron. These children that grow into adults can become toxic on their own iron. Can you imagine? Now, there's all sorts of types of thalassemia. You don't have to know all the types, okay? When they're taking exams and talking to you about them, it's always the worst, the major, the Cooley's anemia. And this is the one that cells burst so quickly that you have to have transfusions to live. But there's more than that. So sometimes babies are born with mommy's blood and they're doing okay, right? Mommy's blood. And then all of a sudden, and their cells look okay. About 6 weeks, they start changing into the rectangular shaped cells. And now they're starting to burst. And now we know low hemoglobin hematocrits are normal in that 6 month old, but you're talking 2, 3 months old. You're seeing those results going really, really low. So this is a child who very quickly in life is burning up the iron and the oxygen of the red blood cells. So what happens? Cells are not being given their nutrition. Cognitive delays, growth delays, all part of it, right? Nutrition, whether it's from the cells or from the food, it's still nutrition for the body. So you will see that they're really much go down. Now, these children need transfusions. Now, how often, I don't know. It could be 3 times a week, like dialysis, once a week. I don't know. It all depends on the child. The child dictates how quickly their blood is being spewed and bursts these red blood cells into the blood volume. It depends on that. But the other thing about this hemoglobin hematocrit and giving blood transfusions, these cells burst, and the iron in the cells cause them to get overwhelmed in iron. They have to take iron chelating drugs, or they need that machine called apheresis, which will just take the iron component out of the blood. It's like a dialysis. Nurses run it. I ran one in the ICU, and it will just pull out what component you don't want. And that's done every so often to get the iron out. But usually they just want to give them the deferexamine or the desferal, and that will help through the kidneys. It combines and it eliminates it. So thalassemia, it's chelation, getting rid of iron, and transfusion. And this kid's going to be a sick kid. He's always great hemoglobin, low hemoglobin, great hemoglobin, low hemoglobin. Can you imagine what that heart thinks? The heart's being worked like crazy, right? These children are getting blood transfusions. Can you imagine how many antigens and antibodies and stuff are going in that blood? And now it's becoming more and more difficult to get blood for that child. You can imagine as time goes on. They usually die from heart disease because high hemoglobin, low hemoglobin, right? The heart don't like it, along with the organ. Now, many times because this cell thing going on drives the body crazy in the heart, they try taking out the spleen. But again, they're immunosuppressed. Many of them die from post-splenectomy sepsis. So it's, what to do, right? Maybe bone marrow, not sure. All right, aplastic anemia. And when we talk about it, we talk about the pancocytopenia. So hemoglobin hematocrit are low, but look at this, white blood cells are low. And thrombocytopenia, what is that? Platelets are low. So, oof, you're low hemoglobin, you have no immune system, no white blood cells, and your bleeding thing of platelets is low, so you're a bleeder. All of these things, aplastic anemia. We treat this just like leukemia. We give chemotherapy for these children and maybe a bone marrow transplant. Okay, lack in hemostasis, bleeding. Well, what's the first one you think of? Hemophilia, right? There's 3 different hemophilias that we discuss in peds. It is factor 8, factor 9, and von Willebrand's. Hemophilia comes from the mommy, the X-linked recessive. Mommy hands it over to them. And the reason why we need to know, where that came from. We can find out what clotting factor is missing. So when you're missing a factor, the blood doesn't know how to clot. They can't put the Band-Aid over it and stop the clot because it doesn't have all the parts of the pieces, right? So when we think of normal hemophilia, it's factor 8. That's what you think of. But there is factor 9 called Christmas. And then there's something called von Willebrand factor. What I think is this scientist named von Willebrand found another factor that he didn't call 8 or 9 or 10. He just called it his name. But it's also with factor 8. Okay, so all of these will bleed. Now, sometimes we don't know children have bleeding problems. And it could be later on in life. Sometimes we know earlier, sometimes we don't. But what would we see? Well, these would be children who bleed and bleed, prolonged bleeding, right? They also fall down on their knees and it starts to swell, which is called hemoarthrosis. And that blood can really deteriorate blood joints. You know, your joints with all that blood, it's caustic. So we concerned about that. And of course, any sort of bruising that's going on. As I said, it's X-linked recessive. And what would you see? Well, in an emergency room, you're not going to get any factors back. That takes about a week. Special labs, right? But we could do a PT and a PTT and a simple CBC looking at platelets. And that's what we would draw. And of course, when those things came back, we would see whatever factor it was that was causing it. And we would see that PTT, which should be, depending on the lab, maybe up to 40, it might be 400. I mean, it'll be very prolonged. You're like, oh, okay, I have an idea of what's happening. Platelets are normal. And then other things we look at with clotting, the parathyroid and the fibrinogen, all of those are okay. So factor 8, PTT is elevated, platelets are normal. How do we treat it? Well, I was blessed to meet a little young, I don't know, about 8-year-old little boy, 8, 9, and his father actually came into the emergency room. He had fallen down and actually hit his knee, and it was bruised. Now, treatment is elevate rice, right? Elevate it, ice it, contain it, you know, and relax, stop the bleeding, and give a factor at home. But there was a question about giving the factor. So he couldn't get a hold of his hematologist. So he came in and our doctor said, give it. And the father and the son said, do you mind if we give it ourselves? And I'm like, not at all. I happen to have an orientee with me, brand new nurse, who was coming in to work in the ER. And she watched this father do it probably as good as I did. And I was always one of these cautious and rubbing things down, washing hands, being safe type things with kids. It was great. And even that little boy chose the vein that he was going to stick it in. And it was just one of those little metal butterflies with the green tips. Put it in, and the kid held it. The father mixed it up because he had to mix it, put it in the tubing, and slowly pushed it in. It was the most beautiful thing I've ever seen. This is how it should be done. Kids at home fall down, excessive bleeding going on, can't control it, give your home infusion. Whether it's factor 8, factor 9, whatever that is, that's what you do, okay? Now, sometimes it's minor, and we can give the desmopressin, and we could give that in a nasal spray. You're also going to see next week, desmopressin is also good for diabetes insipidus. So it's one of those universal drugs. So that's how you would treat it. So with children just diagnosed with hemophilia, you need to protect your house. All those sharp edges, you better put some cushion on them because a toddler is going to be rubbing and getting now bruised everywhere, right? So protect, you rest it, ice it, compress it, elevate it. And that is any bleeding or even orthopedic injuries. That's it. And if we're just finding it out, of course, tell the family they should get genetic counseling, especially mom, right? So hemophilia does well. If we can control the symptoms, we can keep the blood out of those joints and protect them. These children won't end up in wheelchairs and they'll have a pretty decent life. Now, immune thrombocytopenia purpura, ITP, P for platelets. Okay? So this is a lack of platelets. This is a transient, doesn't last forever. It's usually following some sort of viral upper respiratory something. And these children come in because they're having nosebleeds and they never had them before. Remember, I tell you where these nosebleeds are going to come in? Well, this is the one. It could also be in hemophilia too, but ITP, they had a nosebleed, went to the doctor. They said, oh, paint it with Vaseline and you'll be fine. Well, and they have another one. So they come in and they do a CBC, and guess what? Their platelets are low. They have these little tiny purplish, they call it purpura. And the mother said, and some bruising and this nosebleed. The mom said, this kid plays video games all day. I don't know why, he doesn't fall down. There's something wrong here. He hasn't been outside in weeks. I've heard it like that. And then we go looking. So we do the CBC. We're going to find a low platelet count. So this is from a viral infection early, a couple of weeks ago, right? So what do? We're going to give IV immunoglobulins. That's just like Kawasaki, right? IV immunoglobulins. Let's boost our own immunoglobulins and something called anti-D antibody. Now, many of these children, just to be sure, will be admitted in a hospital. So you need to know how to care for them. Well, they have no platelets. They're very low. It could be 10,000. This should be over 100. So it's quite low. We don't usually get platelets. Usually it'll build up with the treatment. But in the meantime, you got to protect them from bleeding. So avoid any sticking. So if you have an IV in, try to get the blood from there. There's tricks and ways that we do that. Watch them for bleeding from their gums, soft toothbrushes. Adolescent girls, sorry, you're not shaving your legs today because we don't want you bleeding, right? Low platelets. These are common sense. You got to remember, every age group, what would you do? Watching stools for that. And again, monitor those blood counts. They will be taking them every day to look at them. See if the IVIG, N-to-D, is working, right? And then, of course, sometimes they do give corticosteroids. So avoid sticks, watch for bleeding, monitor your CBC platelet counts, and of course, those steroids many times are used. So this is probably an NCLEX question. If you haven't gotten it, you're going to get it usually. What do we do in a nosebleed? Number one, calm the child down, right? The kid is going bonkers, heart rate is racing, you're going to be bleeding everywhere. Once you get them calm, sitting on mom's lap or wherever they like, take your two fingers, your thumb and your finger, push it on the bridge of the nose, and have them lean forward. They used to tell me to lean backwards, but you're just swallowing blood, and then I'm going to vomit and it's going to get worse, right? So lean forward, all right? And hold it for 10 minutes. If after 10 minutes it's still bleeding, they need to seek medical care. That's an epistaxis. Now, HIV/AIDS, an immune problem. This came out in the 80s pretty hard. I was working in a newborn ICU at the time, and all of a sudden we were wearing gloves for everything. And before that, we didn't as much, to tell you the truth. We know that HIV/AIDS could be in your newborns. It's from mother to child. It could be older children, adolescents with risky behaviors can have it. Now, in a mother who's pregnant, we can start HAART therapy, which is highly active antiretroviral therapy. Say that 3 times quick. But what it does, we're trying to improve the newborn's immune health. And as they're born, we're putting them on antivirals, again, to improve that newborn's immune function. Do you know a child born from an HIV mother does not have to be HIV positive? I've seen them born and auto-convert by 1-year-old. I'll tell you another story. I was doing clinicals and there were triplets. This little girl had AIDS, one had HIV, and one was perfectly normal. That's triplets out of one time. So anything can happen. It all depends. So in newborns, again, goal is immune function. And again, it's education. And we know with adolescents, again, is teaching them safe sex, how to use a condom, whatever we have to do. Because remember, we can talk to teenagers. You don't have to get mother's permissions. We can talk, give them oral, written information, and give them that sex talk if they need it. So managing any hematological problems. Well, we talked about blood transfusions, right? Remember when you're given blood transfusions to be alert to blood transfusions reactions. We do vital signs before, and then we do it 15 minutes after. Many times I've seen those reactions go from a normal temp, and all of a sudden they're 102. That's usually what I see. I mean, sometimes at the end they're getting jugular vein distension and congestive failure, but that's usually the adult side of blood transfusions, believe it or not. And always follow whatever the protocol of your hospital is. There's always a nursing guidelines for you there. As I said, apheresis was going to remove that iron, right? It just takes what you want out and puts that back in. Whether it's I'm taking platelets out for somebody and you're being a donor, whatever it is. Now, bone marrows are done. And think about a kid getting that little blue thing. And let me tell you what it's like. They numb the outside with an emla cream, right? They do that first. And if they're going into the hip, sometimes it's sternum in adults, but usually kids behinds, they're sedated, but they don't really see. And then they go deep with some numbing to try the best they can. But they take that and hold it in their hands and go, and you can hear the bone going as it gets into the marrow to get it. Have you ever seen one? It's like, ooh, the first time you hear it, it's like, ooh, I didn't expect it. Now, does it hurt that child? Yeah, it does. But with all that numbing, it should be minimal, okay? So again, be honest with the kid always. Tell them that you're going to experience a little pain, but don't move, and we're going to do everything I can. I'll hold your hand, whatever you got to do. So sickle cell. How many, if both parents have the sickle cell, what's the percent that each child will have sickle cell?
50, 100.
25. 25%. If each parent has a trait, every child has a chance, 25% chance of having sickle cell. All right, let's go over some things. Cancer. Let's look at neoplastic. These over the half of all cancers are blood and blood forming. We do have the big tumors in some areas. We're going to go into that. But let's start out with leukemia and lymphomas. Remember, the lymph nodes get filled in your neck and your arms, your groin. They're all over the place, right? So we're going to go into that. So leukemia, what is it? Well, I like this diagnosis. So I'm going up the slide. An unrestricted proliferation of immature white blood cells into the blood-forming tissue. What does that mean? That means your white blood cells are broken. They don't work. They're formed, but cancer's eating them away and they don't work. What do white blood cells do? It's your immune system. It fights infection. So guess what? You have no immune system when you have leukemia. Okay? It's as simply as I can describe it to you. Now, it's more common in boys greater than 1, and Down syndrome children are at higher risk. That's one of the things. It was a question on the HESI. about a Downs and leukemia with a fever. Okay. So that's one of those weird facts, but Downs are more for hypothyroidism and leukemia. And literally, the onset of leukemias are usually ages 2 to 5 in children that we see them. Know that there's two types. You have ALL, lymphocytic, and then AML, harder to treat, myelolytic leukemia. Acute, ALL, AML are the two. AML is the harder to treat. Usually takes a little extra to get that out. So, diagnosis leukemia. I'm going to give you my next door neighbor. This girl was 13 years old, had a bruise on her knee and a couple other bruising, pain in her knee, really, really bad. She was really tired and she had this fever like aching pains flu. And I had gone away for the vacation, so she couldn't come over to ask me what to do for her mother. So she brought her to the emergency room with just that symptoms of bone pain, fever, and that exhausted fatigue and the little bruising. They did a CBC. Her initial white blood count was 0.1. So it was nothing. And she went on. Okay. So how do we do it? Those are your history. Very common to see those things. So you're going to do a CBC and ask for a blood smear. And you're going to see the difference in the cells. And they're going to tell you, yep, it's leukemia. And you're going to see very low hemoglobin and hematocrits. Again, henceforth, all of the tiredness, right? They will do an LP. They want to make sure the cancer is not in the lumbar spine and the meninges and the brain. We'll do that. And then again, this is your bone marrow. Again, always be honest with the children. So you've been diagnosed with leukemia as a child. They always put in a central line of sort. One of the ones that I was very accustomed to was called a port, and it goes underneath the skin somewhere in the middle or right or left chest. It just depends on the blood vessels and where they are. And it's under the skin. So nothing hangs out and can be pulled and snagged. So they don't have to worry about bathing, etc. And they come in, they numb the area with EMLA. In fact, kids with leukemia that are home on treatment that have a fever, the mother will put EMLA with a Band-Aid over the port, bring them into the ER because they know we're going to open it up to give IV antibiotics. So it's something that they get accustomed to. So as they get that port in, the first thing we do is we're going to do induction therapy. It's that first 4 to 6 weeks. And our goal is remission. I said remission, yes. 4 to 6 weeks, goal is remission. So this is where we hit them with how many chemotherapies is the new protocol of the day, of the week, right? They give 2, 3, whatever they take, and they eradicate the cancer. But they don't just do that. They're going to put it intrathecally in the spine. They're going to make sure there's no little things hiding around in there, right? And then the consolidation again, looking for those little sneaky guys who are somewhere in the body and saying, I'm sorry, you can't hide. I'm going to find you. And then they go into a maintenance, okay? And that is the levels. So the induction is the big one. That's the big one. That's the hardest to get through. Now, for leukemia, a hematic stem cell transplantation, can be a cure. So there are 2 types of cells. Now listen how you can remember. There's autologous. Automatically, mine is the best. It's mine. Autologous, mine. Automatically, mine is the best. Allogenic is all the others. So what would be an autologous stem cell transplant? Maybe they saved their cord blood, or maybe they saved their it before time, had already pulled, or they knew about it. But that's mine. all allogenic, it's all the other people. You don't have to have the same blood type. It's relatives, non-relatives. Who's the best next person besides you to give your autologous stem cell transplant? Is your siblings. That's the next best one because it's mom and dad together, just like you are mom to dad together. Okay. But anybody. So again, we're preparing kids again. This is why we did the first couple of weeks, right? Now, this girl that I had, my neighbor, her knee hurt. So yeah, they gave her something for pain. And again, she came in with a fever. She had antibiotics given. They're monitored closely. These kids go home, have a fever, 100.5. They're calling their doctor. They're in the ER. They're getting treated because they know there's no immune system because we're trying to wipe it out in order to get rid of this cancer, right? And of course, blood cells are being killed along the way, not just white ones, red ones, so they are anemic. Anybody who wants to be a pediatric oncology nurse to give chemotherapy, you're probably one of the highest prize nurses in the system. They will pay things like $25,000 sign-on bonuses, for 2 years of service. This is one of those fields that, yes, it's hard to work with. Yes, there's a lot of, suffering here, but it's also a beautiful place to work. You meet great kids, great families, and I always say it's not if the child lived or died, it's what did you do for that child and family while they were here? I was just reading, found an old Facebook page from a mother whose child died. And he was like my kid, Chris. And she always, every nurse's week, every birthday, to Chris's favorite nurse, you will always be in my heart. And this was 15 years ago. The kid died every single birthday. So it can be rewarding and it makes you feel good what you did. Okay. So leukemia, what's the factors? What's the good, the bad thing? Well, what was the white count? Was it 0.1? In fact, my next door neighbor today is a PhD in psychology out of the University of Miami. She's doing well, to let you know at the end of that neighbor story. But it was that white count. 0.1 isn't bad. A 0.01 would be bad. How old are you? Was it the AML or the ALL? Boy or girl makes a difference. And what's your blood type? Are you an unusual rare blood type? You can't get blood products when you need them? Or are you an O positive or A positive, right? Makes a difference. So cancer, we can do multitudes of things. We can do radiation, surgery, chemo, all these sort of things. We know that early detection is what we want, very similar to what I said with leukemia, pain, fever, bruising, petechiae, bleeding, and of course, tired, weight loss, all of that goes with it. And, vision changes because, there's no blood going into the eyeballs either, right? Side effects of treatment, as I said, it's that chemo is coming in and it's killing everything in there. And we have to worry. But, not only taking care of chemo patients, one of the things, blood cells, the neutrophils are white blood cells that really fight infection. And neutrophil count should be about 2,000. So any child less than 500 neutrophils, 500 or less, I mean, even 600 is actually pretty low. You really want to pay attention. Remember, there's no immune system when they're that low. So they need antibiotics started, or they are going to go into shock on you because there's nothing fighting it. So neutrophil counts, always a priority, always a patient that if you get one in your group to see, you hear it, I would see them first and I'd evaluate them, make sure they don't have a fever because you don't want a child going into septic shock on you. And we know with anyone that has a low white count, preventing infection is priority. Hand washing, right? Remember, the blood cells, the red blood cells and the white blood cells are all being, destroyed with chemo. So remember, hemorrhage is a big thing. They shouldn't be out doing all the sports they want during this time. Kids, they still want to get up, go out, they're feeling a little better, they got a blood transfusion, their energy. They shouldn't go out on their bike or whatnot at this point. Swimming, again, swimming is always a great sport. As I said, anemia is very common, and yeah, they're going to get, tired easily, very common because all cells are done. We always heard chemotherapy. We always think about vomiting, right? Vomiting, vomiting, vomiting. Again, when I started nursing, you couldn't give an antiemetic till the patient vomited, and then you could give it. How ridiculous is that? So I used to say they're nauseous. Oh, they vomited, and I give it to them anyway. And then, of course, it came out with, research that it was the best practice to medicate before because we know synthetic cannabinoids are being used. I've watched many documentaries. It's controversial, but it is a homeopathic thing. And as long as the parents and the physician know what's going on, so there's no side effects from combinations of anything, if it works, it works. And again, give it before. They're not going to want to eat, their tongues is going to be sore. Make sure that we give them anything they want, high fat, high protein, high calorie. Give them the most hearty, whatever it is that they do want. And these children, how do you measure if they're getting nutrition? Height and weight. And then the albumin, transferrin, those things are measuring proteins and nutrition in the body. As I said, those mouths get really bad. Again, try to soft toothbrush, try to keep as clean as possible. And it's mouth to anus, the whole GI. So again, if they need to sit in a bath because they're having hemorrhoids or whatever, do that. One of the things we don't think about is children that aren't eating, they're in pain, getting pain medicines. And remember, hemoglobins are low, platelets are low, chance of bleeding is high. Bearing down for a stool could cause a stroke. In fact, you always worry about strokes in these low bleeding things, platelets or hemophilia or any of those. If they're complaining of headaches, always worry about those sort of things. And of course, medicating for pain, keeping them comfortable, they might eat better. They get blood in their urine, and of course, they get loss of hair. I've had fathers, I've had brothers, uncles shave their heads. I used to bring in these little spools of ribbon, and I'd make little headbands, and I'd wear the same headband with my little kids, whatever it was for the day. And we sent home one for the sister or the mother or whatever. It just makes having no hair more fun, isn't it? I got pretty colors on my head. And steroids are given. Remember those signs of too much steroids and Cushing disease. Older kids will be more feeling bad about it than younger kids. Just make sure that the clothes aren't tight and let them be comfortable. Preparing them for those bone marrows, again, they will be sedated, get them ready on their level, and make sure that they do use topical and deep lidocaine. I've been in places where I said, no, you're going to numb it first. And as a nurse, you can do that. Pain management, it's not all about the morphine. Remember, acetaminophen, ibuprofen all work well, and it's not all about drugs. It's positioning, it's distracting, it's warm, it's cold, whatever works. All of those things together help. And those low dose around the clock, there's nothing better than that. In health promotion, keeping them immunized, keeping them, preventing them from getting diseases, knowing that these children will not get live vaccines, right? This is one of them. And varicella can kill them. So they have to get that varicella vaccine. And if they're worried about, can mom and dad get it? Not all the live vaccines, but they should always, always ask. Now, this is a question about 40% of you will get wrong on the exam. And it's about Hodgkin's and non-Hodgkin's lymphoma. Well, where are lymph nodes? They're in the neck, underneath the arms, they're in the groin, diffusely all over the place, right? It starts in the lymph system, and part of the system is the liver, the spleen, the bone marrow, and then it goes to the lungs, etc. Right? Hodgkin's, now this is how you're going to remember it, is a lodge. It's a house. It's big. You can touch it. You can feel it. It's painless, enlarged, cervical, and above the shoulders. Supraclavicular, all up here, is Hodgkin's. It's a house. You can see it, feel it, touch it. Okay? What would be the problem with this Hodgkin's, this big and large, painless thing? Usually they're like, oh, I got a lump, it don't hurt, they don't feel bad, they're fine. Well, then they start with fever, and this gets bigger and pushes against the airway, the esophagus. That's when the problems will come in. So we have to make sure we get it before it includes. So what do? Well, we look at them. We see this big lodge, this house, this Hodgkin's lymphoma on their neck and one of those lymph nodes. And of course, it's the history physical, getting tired, this big thing that's been growing, a CBC, right? Normal CBC. They do uric acid in the liver, just looking for kidney and liver function. And then they look for inflammatory processes. Your C reactive protein, probably one of the most common with a CBC that you use in pediatrics to look for inflammation. In the adult world, it's the ESR or SED rate, but the CRP is really, into the pediatrics. So you got this big thing. You can feel, you can touch it, you can stick a needle in it, and you can get a biopsy. With it, you see Sternberg Reed cells. Treatment, radiation, chemo, or both, depending on what they want to do. Always remember, any radiation marks, please don't wash them off. They're purple, they're annoying, but they know where to direct that radiation for the next time. When do you do radiation? It depends on the child, depends on the condition. There's very many variables in radiation. And of course, with this, there is a high risk of infertility because you're doing radiation, which can do it. Also, it's the chemo. Now, the other one, I'm not a house lymphoma. I'm a non-Hodgkin's lymphoma. I'm diffuse, little bits and pieces everywhere. Can you remember that one? It's everywhere, diffuse, but it's the same thing, all right? It's in the lymph nodes, but it's very small, it's tiny, it's all of the other extra little places all over. Again, they try to get a biopsy, do bone marrow, whatnot. Again, chemo, radiation, to get rid of it. So Hodgkin's, it's a big lump, painless, enlarged lymph node above the shoulders. And non-Hodgkin's is not a house. It's diffuse. It's everywhere. I don't know where it all is. It's everywhere. Brain tumors, most common of the solid tumor in children. Sometimes it's benign, sometimes not. What would you see? Well, usually you're going to see things, headache and vomiting, that get worse. So the headache, you get a headache, but it gets worse as time goes on. Vomiting, not related to eating. It's like you just don't feel good. And then, of course, the pressure is pushing any eye issues, swelling on the brain on younger children, the head's getting bigger, problems walking, ataxia, diabetes insipidus, which is a posterior pituitary, has pressure on it, pushing it, and that monitors fluid in the body. So all of a sudden, this child is urinating, peeing, and they're not going to grow. Again, it's all of that pressure in the head. So we're going to look at what it looks like, and we're going to do CAT scan. We're going to be doing MRIs, whatever sort of, imaging we need. And if there's not pressure like a hydrocephalus, that we wouldn't touch. But we're going to do a lumbar puncture. is there any cells in there, right? And if we can get a biopsy, what is it? Now, surgery can be really tricky. And I think parents have a hard time with a brain tumor post-op because they've got their hair shaved and they've got these big incisions on their head. A lot of times they'll do radiation. It's going to shrink it because we don't want to take out a lot of tissue. We want to take out the smallest possible. And of course, chemo just to make sure we're keeping it all contained, right? So post-operatively, these children, many of them have a drain in. It's like a Jackson Brat type thing or other things. And you have to be careful on positioning. Remember, you've taken a piece of brain out. There's an empty space. Can you turn it on that side or not? Can you elevate the head of the bed or not? Okay, very important. The other thing is you cannot overload them with fluid. You overload them with fluid, it's extra pressure in the brain, okay? Now, neuroblastoma, it's not a common type of tumor, but we mention it. It starts in the abdomen, and by the time we know it's there, it's already in the brain. It's already metastasized. And you'll see this mass. I mean, to get as large as this little baby is big, but you see this problem in the tummy, then they're absolutely going to start looking at the head to see if there's any symptoms. I'm just telling you, the biggest point is by the time you know you have a neuroblastoma, it came from the abdomen and it's already metastasized. One of the things about neuroblastoma, it's not a big percentage, but again, this child has brain and abdomen covered, and it's really not an easily curable diagnosis. It's a quite devastating one. Bone tumors. One of the things about bone tumors, the one that you see the most is probably on the femur bone. And what happens is it starts out with an annoyance, maybe a little limp, and it progresses to the point where you can feel it and you can get, if you live going on and on, go respiratory distress, et cetera, et cetera. Now, bone tumors can be cured. So get into the doctor. I'm having trouble, especially in the morning, or when I'm getting up, they're thinking it's rheumatoid, but let's take an x-ray to be sure. They find this little mass on the femur bone. It could be anywhere on it, okay? And especially with all the other things that you're seeing, do a blood count. It's a cancer, so your blood count's going to be low. And your immune system's down. You might have been getting sick lately too. Now, that osteosarcoma that's now on the femur, they have to take the whole femur bone out, not just pull off that tumor. The whole bone needs to go. So can you imagine you're just left with a hip socket, right? No, they take the lower leg, turn it around and put it up into the hip socket, connect it all up. And that's called salvaging the limb. Crazy, isn't it? So our goal with this is it's chemo. It's also radiation. A lot of these are adolescents. Can you imagine all of the emotional stuff that goes on with it too? So that's part of it. Wilms tumor is your kidney tumor. And it's an extremely, extremely fragile tumor. And just assessing and touching the abdomen, little cancer cells can be broken off and it can cause metastasis. So, big thing, do not palpate abdomen. And if you're changing diapers, to be careful. I saw one 3-year-old boy came up after the Haitian earthquake that was down there. Our hospital went there and they sent him up and this religious group picked him up from a Miami airport, brought him to my hospital. I'm in triage, and said, "Here he is." And I'm like, "So who is he?" They go, "I don't know." And they have the records. I said, "Okay." It's all in French. So now I've got to figure out what's wrong with the child. So I do an assessment. I get on his level somehow. I make him giggling. We don't speak the same language. And I feel his tummy. And on the left lower quadrant, I felt a big, hard, soft bile mass. And for some reason, I knew it was a Wilms tumor. So what did we do? We did, the ultrasound. We figured it out. What they'll do is chemo, sometimes radiation. They do surgery. And this kid today is doing well. Apparently, the floor where he stayed on, he had somebody write them a note to tell him thank you for it. This surgery is through the abdomen right to the back. And that's where the kidneys are, right? So always remember there's always problems with urine. It's a kidney tumor, also bowels because of the manipulation in there. And then, of course, you always worry about infections with, chemo, radiation, et cetera, post it. But the biggest thing, do not palpate. A retinoblastoma is a tumor in the eye. This looks like when you turn on your light outside and you have like a forest behind, or open field in your backyard, and you see an animal and you see those white shiny eyeballs, a cat, a dog, a cow, whatever. That's what it looks like. And it looks like that picture there. So you would see that. If we see those things, we would say, "So what's been going on with this child's eye? Have you seen anything?" They'll do radiation, they'll do chemo, and they'll take the eye out. The whole thing has to come out. And they usually end up with a prosthesis. They should do okay. I've met one of these, and it was an 8-month-old girl that it was in. And I know that she had surgery, and the last thing I heard, she was okay. And testicular examination for men should be done every month, right? And I'm going to tell you why. An 18-year-old boy walked into the triage room complaining of testicular pain. I was in there with another nurse. The nurse examined, put gloves on, examined, and the testicle was like very large. They took him back, they did an ultrasound, and then they just did an x-ray of his chest. He already metastasized to his chest, and I found out he died 3 months later. So testicular self-exam, very important, and they do take testicular cancer and pain very seriously in urgent cares. Could be just a torsion, a twist or something. Livers tend to grow back. So that's pretty neat if we can just remove just a piece. If not, transplant, it's fine. And, I have watched such changes. I was thinking back, I've been a nurse, wow, almost 50 years, believe it or not. I've done a lot of different things in nursing, and I've watched cancer and what they used to not treat, and now that they do treat and there's outcomes. So as you go on in your career, you're going to see the same thing, where things that they couldn't treat before, they're going to treat it easier, simpler, and they're going to get through it. And we know it is us nurses who make their lives so much better by what we do until they get to be cancer free, right? Well, I was long winded today. It was a very, very long chapters. Um, I'm going to send you the cahoots. Or do we have time? You have time for a cahoots? Who's going to win? Who wants to win? Oh, Sam wants to win, guys. Be careful. He's tricky. I hope I explain things in a manner that make it a little bit simpler for you. I think that you learn the big picture and you just can't put the pieces together until you put a little common sense on it. And you're going to find out that's what nursing is. It's only common sense. You need a little knowledge. And then when you don't know, always ask. I remember as I was going back to school in my higher degrees, I would all of a sudden ask somebody a question that seemed so simple. And they go, you know that answer. I said, no, my brain ain't working. Please tell me. And they admired that because, I'm human. Everybody in who want to be here? Let's get her done. Week 6, halfway through. Which statement best describes a neuroblastoma? Remember, a neuroblastoma starts in the belly, gets big, and by the time we realize it's already in the brain, it's already almost too late. What is a priority treatment for a newborn of an HIV positive mother? Remember, I've seen HIV when it first came out in the 80s. I remember when they found it, and what we did as nurses, all of a sudden we had gloves, which we didn't have before. And I've seen that in also, the newborn ICU. And it's all because of the antiviral drugs we have. So improve the infant's immune system. Give that child a chance, okay? That's mom, if you can, and at birth. What are symptoms of sickle cell anemia? Well, what happens? It gets cell, it clogs bifurcation in blood and it gets swollen and blood can't pass. What do you see? And remember, blood cells are everywhere. I think probably what scares me most with sickle cell, they come in complaining of a headache. I'm worried about a stroke. Or coming in with severe eye pain, and that's their eye vision is affected from the sickling of cells. Sickle cell anemia affects which cells? It is red blood cells. Sickle cell is anemia, affects hemoglobin hematocrit, or red cells. What kind of hematocrit would someone with sickle cell have and why? An admission to the ER in a sickle cell crisis, what sort of hemoglobin hematocrit would they have and why? So remember, sickle cells don't live long, they die. So they're lower, period. Okay? What I told you is sickle cell children coming in crisis usually have a hemoglobin of 5, 6, or 7. If it's 7, I'm happy. Usually a lot lower. What is the treatment for sickle cell anemia? So IV fluids dilate the vessels, let that blood, those cells to get through, medications, pain medicines, IV antibiotics, blood transfusions, and then maybe a bone marrow. What is the reason children with iron deficiency anemia are easily tired? Again, look at the question. Iron and anemia. Where is iron in the body? The iron is carried by the red blood cells. So if you're you're tired, you don't have iron. You don't have enough cells to carry it. Aplastic anemia includes a depression of which blood cells? So when we say aplastic anemia, it's the pancocytopenia, all right, on that slide. It's your red blood cells, so you're anemic, white blood cells, so you're immunosuppressed, and platelets are low, so you're going to bleed. That is aplastic anemia, and we treat it like leukemia. What is the most common type of anemia? Iron deficient anemia, yes. How do we treat it? Mostly diet. What causes pernicious anemia? I love that word, pernicious. Has to do with the intrinsic factor, which is B12 deficiency. Yes, I remember that from biology. Which symptom is the single most common symptom of anemia? And this is usually why parents bring children in. It's fatigue. I'm tired. Something's going on. When teaching parents about beta thalassemia, the nurse informs the child's at risk for what? That's the rectangular shaped cells, and the red blood cells burst. So, what's in red blood cells? Oxygen and iron. So, you'll be hypoxic, and iron needs to be removed to chelation therapy. Okay, making sense now, that repetition. What lab values will you see with hemophilia? Remember, you're not going to see factors. Go to an ER, go to a doctor's office. It's going to pull normal sort of labs that can be easily run with quick results. This is that PTT, which measures heparin, right? Heparin's all how much heparin in the body are we, making the blood thin as we want to. That is prolonged with no medicine. But the PT, which is the coumadin side, normal. Platelets, normal. Priority treatment for a child with sickle cell crisis is priority. What do you do first? Number one, IV fluids. Number two, heat at the same time with pain medicine. And to elevate it, maybe, maybe not. Remember, IV fluids. What is immune thrombocytopenia purpura? E for platelets, right? ITP for platelets. That's how you remember that one. So, decreased number of platelets in the blood. And this is usually due to some sort of upper respiratory before. Yes. Thrombocytopenia can cause the following symptoms. So thrombocytopenia has not enough platelets, so there's bleeding. With that bleeding, you'll see that petechial, that little purplish stuffed looking thing, almost like when you vomit and you see that little petechiae in your face. That's what it looks like. Bruising, and the epistaxis is usually the one that we find ITP with. It's the nosebleed, believe it or not. It's what I've seen most. Multi-select. Child with hemophilia has fallen and the knee is swollen and painful. Treatment would include what? Remember, it's price, right? Protect if you've just found it out, but it's rice. You need to elevate it, you need to ice it, you need to contain it. These children, you're not going to exercise it, you're going to keep it elevated and still. Never hot packs, always cold, stop the bleeding, right? So remember rice. Rice is a number you'll name that you should remember. What is a priority nursing action for a suspected blood transfusion reaction? All of a sudden, they're running a fever of 102. What are you going to do? Stop it immediately. There's no second guess. You disconnect it from the hub as far down as you can, flush it, and just put up some normal saline. And then you send everything back to the blood bank. Number one, stop it. A child is admitted with neutropenia. Which nursing action takes priority? What is neutropenia? Thrombocytopenia. And this is just hand washing, right? This is just universal precautions. This is wash hands, making sure a mask if you have a sniffle, protect the child. Neutropenia, decreased white blood cell. They have a better chance of getting sick from you or anybody. Which symptoms would a healthcare professional expect to see in a child with leukemia? What did my next door neighbor go to the ER with? And that's bruising, fatigue, and bone pain. Remember, leukemia, white blood cells are low, infection. Your red blood cells are low. They're going to be tired. And the platelets are going to be low. So they're bruising. So if you remember all those things, that's it. And of course, pain. Your child with ALL has a recent lab results with platelet counts of 10,000. Your nursing action, what do you need to do? What does platelets of 10,000 mean? And it doesn't matter what your diagnosis your child has. They could be in with an upper respiratory. It doesn't matter. They're telling you with a platelet of 10,000, I can bleed. So you need to be put on precautions. Very good. A multi. A child's placed on bleeding precautions for ITP. What interventions would the nurse do? So you don't want any injections. You're going to look for bleeding, whether it's in the gum, stool, urine. Um, you're not going to give any of them a razor. I'm sorry, you're going to have a beard if you're a young teenage boy or a girl. Sorry, your legs are going to be hairy. No, you wouldn't do that. Monitoring the CBC, very important, and then treat with corticosteroids if we're seeing bleeding going on. So all of them, you're going to see that again. Child with Wilms tumor, which action by a nursing student causes the faculty member to intervene. As in, what shouldn't you do? So remember, it's a renal or a kidney tumor, and it's very fragile. And to touch it, it will break off and cause metastasis in the abdomen. So leave the tummy alone. Very good. Cancer of the body's blood-forming tissues, including the bone marrow, is what? And that is leukemia. Lymphadenopathy, that is the lymph system. It's not the blood. A child with ALL has a fever of 100.5. What should they do? What is the alert? So we have a child with acute lymphocytic leukemia. They're now having a fever. They have no immune system. At that point, they need to call the doctor and get an antibiotic. You can't just take an antibiotic without calling the doctor first or getting to medical attention. Okay. So remember, any child immunosuppressed with a fever of 100.5, sickle cell, ALL, CF, all of them, they're going to say, go and get medical treatment. Call the doctor or get to a treatment because you don't have immune system. You'll go into septic shock. Child is having a bone marrow aspiration. What should you tell the child? Again, always be honest, because if you're not, they're never going to believe you, okay? Most common clinical manifestation of a retinoblastoma. You know what I've said? I've only seen one of these, and it's that white shiny eye. It's like, as I said, cats, because in the dark with a light on, you'll see their light shining, a fox, a bear, anybody, you'll see that. And that's what it's called, cat's eye reflex. Your child has been diagnosed with a retinoblastoma. What information is important? What should you know? You've seen that there. Now you need to do that history. It's information you need. I mean, we've done the physical, we see it. Now saying, figure something out, where'd it come from? Again, you want that history. Has there been any problems or is this sudden onset? Okay. And then go from there. Very good. A goal of surgery for a child with an osteosarcoma is, as I said, most of the osteosarcomas are the femur bone. They can be in any bone. But remember, if it's in a bone, the whole bone needs to come out. You can't just take a piece of it or scrape it off. It doesn't work that way. So if we're taking out a femur bone, there is only a hip hole there left. There's nothing to go in the socket. So they take the lower leg, turn it around, and put it in so they can put a prosthesis, and these children can now be ambulatory. Okay? That's what that's all about. True or false? Immunizations causes autism. And the answer is absolutely not. I put this question in there because there was a research study that came out, which they found out was a false study. That physician's license was taken away, but he said that the chickenpox vaccine caused it, only because we don't diagnose autism until 2, and that chickenpox varicella vaccine is given somewhere between a year and a half and 2 years old. And that's where that came from. But No, immunizations prevent diseases. A child is complaining about skin markings for radiation therapy should be told what? You have to leave them there. A guideline where that radiation machine pushes. They've done this absolute measurement to get to that point. You don't want them to take it off to redo it. If it's now did the first therapy or the eighth therapy, does this one now exactly the same spot? And that's what they want to do. Leave it alone. Multi. Nursing care of a patient with immune thrombocytopenia purpura, ITP. I asked you before, I'm asking you again. So, no IM injections, bleeding precautions, monitor blood counts, yes, and corticosteroids, yes, for the ones that are still bleeding. Now, why do we need IV fluids? We don't. Sickle cell disease needs to take the vessels and dilate them to get the blood through. This has nothing to do with blood cells. This only has to do with that little bit of bruising that's going on and petechiae. IV fluids, no, remember that. ITP does not need fluids. Sickle cell is priority to have IV fluids, okay? It's a very commonly missed question. When distraction is used, it helps what? So it takes the pain away because you're not thinking about it. You have pain there, but your mind is on something else. And it does help. I've seen um, distraction just turning on a TV program, giving them iPad, a video game, crayons, stickers, checkers, whatever. It helps. It really does work well. What assessment question needs X to a child with possible rheumatic fever? I'm throwing in some questions from last week also. Very important concepts. Rheumatic fever is caused by possibly a strep throat. And remember, we're going to come up to acute glomerulonephritis. It's two things that can happen from a strep throat, but that's week 8. You'll get there. Signs and symptoms of asthma. Remember I said there's the upper airway, laryngeobrachial bronchitis, and then there's the lower airway, pneumonia, asthma. Remember, it's expiratory wheezing on asthma. And remember, croup is always inspiratory, okay? Good. Okay. What symptoms should be reported to the healthcare provider for a child with sickle cell disease? Maybe you say priority. And we know that a headache could be a stroke. That's why that's so important. Swelling of hands and feet are a normal thing. Yes, it should be reported, but not. Maybe I should reword the question as in what are serious symptoms that should be reported quickly. And of course, chest pain. Is it in the chest, wall, or is it inside, in the heart, right? Because you can sickle inside a coronary artery. And sores that do not heal, that would not be unless you've had a sickle cell crisis, and let's say a finger, and you didn't get it treated, and now you have a sore on the end, and now there's no blood flow, so it'll get to the point of necrosis. Absolute contraindication for nasotracheal suction include which of the following? So remember, anything that has to do with the inside of the throat, croup, it's already swollen. You don't need more. Epiglottitis, you can't breathe, period. And then, of course, tonsillectomy, you don't want to dislodge that clot there because they will bleed. So it's all the above. Very good. Iron dextran was given via which route? My first injection as a student was iron. And it was a younger woman in her 40s, as I remember. First injection, and I had to do a Z-track. I was so scared. But I want you to know that the lady said that I did a great job and it didn't hurt. But can you imagine? First IM injection on an alert patient was a Z-track. Why do we do it Z-track? Well, it stains the skin and it burns if it gets on the skin. So you put it in and it's like a lock and load, as I call it, and it can't come out. If a child was to receive their own bone marrow, this is called a blank transfusion. Remember, automatically mine is the best, and everybody else is all the others allogenic. Excellent. You won't forget that one. What cancer may be present with painless, firm, and enlarged cervical nodes? And that's Hodgkin's lymphoma. Excellent, excellent. And remember, it's above the shoulders, you would say, above the sternocleidomastoid, the supraclavicular area. A multi. When teaching about sickle cell disease, you would include what? So anything that constricts vessels would cause you to teach. So if it's cold out, you dress warmer. You go in an airplane, you drink more fluids. Always take pain medicine before it gets too bad. We know that. We're going to increase fluids like crazy. And of course, any fever must go call the doctor. They're immunosuppressed. They need antibiotics. Very good. Good job. Thalassemia major is treated primarily with what? And children with thalassemia do have these shaped faces like this also. It's like their bones get misshaped. So thalassemia major, red blood cells burst. It spews oxygen and iron into the blood, and the body doesn't make cells. So blood transfusion is the answer. And you would have a low iron diet because iron's being spewed, okay? Multi. What are opportunistic infections of HIV? Is there any difference from adults to children in opportunistic infections of HIV? The answer is no. It's the same. So any sort of yeast, Candida, absolutely, and then the pneumocystic pneumonia. We know respiratory is the pneumocystic pneumonia, and we know Candida in the mouth, or in women in the vagina, or infections and sores and creases and skin, all of those things. A multi. Treatment of an osteosarcoma includes You see how I take those tricky questions and I bring them back just to make sure you remember them? So sometimes we can't salvage a limb and they just have to amputate completely. It's going to be more difficult to put some sort of prosthesis to walk, but it happens. We do give chemo, we do radiation, maybe. And salvaging the limb is the optimal thing if we can take the lower leg and put it on for the prosthesis. Stem cell transplant has nothing to do with cancer, this cancer. So it is not stem cell. Multi. Who are the best donors for bone marrow transplants? These are donors. Excuse me. And we know it's either me, if I have something stored, automatically mine is the best. And if it's not mine, the all the others, the sibling is the top of the list. Very good. What is the most common opportunistic infection for children with HIV? And it is the PCP pneumonia. You know, I'll tell you a story about in 1980s, I went to work as an agency nurse at a big county hospital in the medical ER. And I had an HIV patient code and had PCP pneumonia. And it was so new, I didn't know what PCP pneumonia meant. And I had to stop and go back and look it up. So PCP pneumonia, I'll remember that for a long time. What a scary place to work. It was fun, but scary. What would you consider to be neutropenia or a low neutrophil count in children? And remember, if you're given a group of patients and one of them has a low neutrophil count and has a temperature, that's your priority. And those are priority of care questions that you will see. So yes, less than 500. Normally they're about 2,000. Less than 500, there's nothing to help that child fight. A primary characteristic of a brain tumor is what? So symptoms get worse because now let's say brain tumor, it's getting bigger, pushing on more things there. And then vomiting is related to nothing. They're getting off balance and headaches are getting more severe. Okay. That's why the other ones weren't there. The optimum treatment for an osteosarcoma is number 3 for you. And that is salvaging the limb. That's optimum. That's what we want. Yes, we might have to amputate, but salvaging the limb we want. And last question. A child is receiving the induction of chemotherapy. What does that mean? Remember, there's 4 stages of chemotherapy. This is the first stage. And it's that initial intensive chemo, and our goal is remission. And remember, they keep going because these little cancer cells hide in places, and we're just trying to wash them out and get them all to make sure that you are in remission, that you stay there. All right. Good job, guys. Alia, good job. Julie, good job, Julie. Chelsea, good job, Chelsea. Klua and Amber. It was a good day for everybody. So remember, send me your diagnosis that you want to do your project on. If you don't know yet, I understand, but remember before the project, please get it to me. Again, send it in early. At least start with your APA paper is a good thing. I know this week is crazy. You're going to start studying, but see when you can do it to get it in. Instead doing it all at one time on week 8. Remember, this week is all of the reviews, and yes, all of them. As soon as I'm done, I post reviews. I take that very seriously because I know that you need them really, really quick. So that is done for you. And mine is Thursday, and you have the other ones listed. There's one on Saturday morning at 10 a.m. So listen to at least 2 of them if you can. Me and somebody else, okay? Get that other opinion of it, whoever you do like. Remember, you do have the CJ Sims, you have your NCLEX questions. You guys have been really good at that. I've not really had to send any reminders, so thank you so much for that. And that's all I have for today, guys. So have a great day. If anybody needs a one-to-one before the exam, let me know. I'm always willing to go over concepts you don't